Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 205 of our Pharmacotherapy MCQ series, which is a collection of clinical vignettes. And the first question reads, CSH, an accident victim is admitted to your neurosciences ICU with traumatic brain injury, abbreviated as TBI, with an external ventricular drain, abbreviated as EVD. This patient's pertinent vitals include a blood pressure of 140 systolic, 90 diastolic, a heart rate of 90 beats per minute, a respiratory rate of 22 breaths per minute on mechanical ventilation. CSH is currently receiving IV propofol at a rate of 30 micrograms per kilogram per minute and 3% sodium chloride at a rate of 30 milliliters per hour via a subclavian central line, with the EVD set to drain. CSH's most recent serum sodium is 138 milliequivalents per liter. CSH's intracranial pressure abruptly increases to 40 mm of mercury, and the Glasgow Coma Scale score decreases from 10 to 5. So my question to you is, which of the treatment options listed below would be indicated in CSH's clinical scenario now? Would it be A. Administer phenobarbital 10 mg per kilogram IV over 10 minutes? Or B. Administer 30 ml sodium chloride 23.4% IV? Or C. Change propofol infusion to midazolam IV infusion at 4 mg per hour? Or would it be D. Increase propofol infusion to 40 micrograms per kilogram per minute? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Administer 30 ml sodium chloride 23.4% IV. Sedatives, such as propofol and midazolam, are considered an alternative to hyperosmolar agents for patients like CSH with TBI, but they should be considered only if hyperosmolar therapy, e.g., hypertonic saline, is ineffective. There is no potential benefit to changing from propofol to midazolam in CSH. Administration of hyperosmolar therapy, either mannitol or hypertonic saline, is indicated for CSH based on the presence of neurologic deterioration. Sodium chloride 23.4% is an appropriate choice based on the patient's current serum sodium level, 138 milliequivalents per liter, and availability of central line access for administration. Barbiturates, such as phenobarbital, are second-line therapy for patients like CSH with TBI. There is no potential benefit to administering phenobarbital prior to maximizing hyperosmolar therapy, e.g., hypertonic saline, in patient CSH. Please advance to the next question. And the next question reads, KSL, a 65-year-old female patient presents to your accident and emergency department with a chief complaint of altered mental status due to a thalamic intracerebral hemorrhage, abbreviated as ICH. She has a past medical history significant for uncontrolled hypertension. A CT scan shows a 3.5 cm hematoma with effacement of the cerebral sulci and transtentorial herniation. KSL's current Glasgow Coma Scale score is 7. So my question to you is, which of the interventions listed below should be provided to KSL first? Should it be A. Insertion of an external ventricular drain? Or B. Administration of corticosteroids? Or C. Cerebral microdialysis monitoring? Or should it be D. No intervention is indicated at this time? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Insertion of an external ventricular drain, and I will tell you why. To prevent further complications, insertion of an external ventricular drain or surgical evacuation is recommended for this patient. Cerebral microdialysis is not currently recommended for patients with transtentorial herniation due to the limited available data supporting its use. Additionally, it is not known whether monitoring of brain biochemistry improves the management of ICH. Corticosteroids are not recommended for patients with ICH. These agents do not reduce intracerebral pressure, and they increase the risk of complications, including infection and hyperglycemia. Given the depressed level of consciousness and presence of transtentorial herniation in KSL, the intervention of first choice is placement of an external ventricular drain that allows bedside monitoring of intracerebral pressure and drainage of cerebrospinal fluid. Please proceed to the next question. And the next question reads, PTV, a 72-year-old male patient who was admitted to the trauma ICU with a traumatic subdural hematoma following a fall at a construction site where he works. His current chemistry panel is as follows: serum osmolarity 245 milliosmoles per liter, serum sodium of 125 milliequivalents per liter. PTV has poor skin color and dry mucous membranes. So my question to you is, which of the options listed below would be the most appropriate initial therapeutic strategy in PTV's clinical scenario? Would it be A. Conivaptan 20 mg IV bolus? Or B. Fludrocortisone 0.1 mg orally once daily? Or C. Fluid restriction to less than 1,500 ml per day? Or would it be D. Volume repletion with IV 0.9% sodium chloride? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Volume repletion with IV 0.9% sodium chloride. This patient has laboratory values consistent with cerebral salt wasting, low serum osmolarity and serum sodium. The initial therapeutic plan for PTV should involve volume repletion to correct the serum sodium. Fluid restriction is not an appropriate plan for patients with cerebral salt wasting, although it should be considered for the treatment of syndrome of inappropriate antidiuretic hormone. Fludrocortisone is considered a second-line therapy for cerebral salt wasting, and it would be an option if volume repletion is ineffective. Conivaptan is a treatment option only for patients with syndrome of inappropriate antidiuretic hormone. It would not be an appropriate treatment for cerebral salt wasting in PTV. Please progress to the next question. And the next question reads, LDP, a 67-year-old male patient is admitted for worsening disease burden related to his metastatic lung cancer. On admission his serum sodium is 125 milliequivalents per liter. He has a past medical history significant for lung cancer, and metastatic disease to the brain. LDP receives a 1 liter bolus of 0.9% sodium chloride IV, and his serum sodium decreases to 122 milliequivalents per liter. No acute changes in his neurologic exam were noted after administration of the fluid bolus. So my question to you is, which of the options listed below would be the most appropriate next intervention in LDP's clinical scenario? Would it be A. Initiate tolvaptan, or B. Initiate fludrocortisone, or C. Fluid restriction? Or would it be D. Repeat fluid administration? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Fluid restriction. The decrease in serum sodium following isotonic fluid administration in LDP is consistent with the syndrome of inappropriate antidiuretic hormone. Treatment with fluid restriction is the best option for LDP. Fludrocortisone would not be an effective treatment option for LDP's SIADH. Tolvaptan is an option, but it should only be considered as second-line therapy for patients with SIADH who fail to respond to fluid restriction. Please proceed to the next question. And the next question reads, MTM, a 37-year-old female patient who was recently hospitalized for spontaneous intracerebral hemorrhage due to warfarin, which had been prescribed for an acute pulmonary embolism with the dose adjusted to an international normalized ratio (INR) goal of 2.0 to 3.0. After a 12-day hospital admission, MTM has improved and is due for discharge to an acute rehabilitation facility. The neurology resident on duty asks for your recommendation for anticoagulation on discharge for MTM since she hasn't completed her treatment for the pulmonary embolism. So my question to you is, which of the options listed below would be the most appropriate treatment regimen for MTM on discharge? Would it be A. Initiate aspirin 325 mg orally once daily instead of warfarin? Or B. Initiate apixaban 5 mg orally twice daily instead of warfarin? Or C. Restart warfarin with the dose adjusted to an INR goal of 1.5 to 2.5? Or would it be D. Anticoagulation should continue to be withheld for 28 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Anticoagulation should continue to be withheld for 28 days. I will clarify why this is the best decision. Anticoagulation should be withheld for at least 4 weeks to avoid the risk of recurrent ICH in MTM. There are minimal data to suggest what agent is preferred for the treatment of pulmonary embolism when anticoagulation is resumed in MTM after 4 weeks. Please proceed to the next question. And the next question reads, BJP, a 68-year-old male patient is admitted to the ICU from the general medical ward with septic shock. BJP has received adequate volume resuscitation with 5 liters of crystalloids, and a passive leg raise test indicates that BJP is no longer fluid responsive. Regarding his pertinent vitals, BJP's mean arterial pressure, abbreviated as MAP, is 55 mm of mercury. He has a heart rate of 85 beats per minute, central venous oxygen saturation abbreviated as SC, VO2 of 65%, with a norepinephrine infusion running at the maximum recommended rate. So my question to you is, which of the vasopressors listed below would you recommend adding to norepinephrine in BJP's current regimen? Would it be A. dopamine, or B. dobutamine, or C. phenylephrine? Or would it be D. vasopressin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. vasopressin. Vasopressin is correct because it is a preferred agent to add to norepinephrine in patients like BJP with septic shock receiving norepinephrine at the maximum recommended rate, according to the 2016 Surviving Sepsis Campaign guidelines. Vasopressin may be added to help BJP achieve his target MAP and decrease norepinephrine requirements, which reduces the likelihood of adverse events from high doses of norepinephrine. Phenylephrine is inappropriate because it has almost pure alpha-adrenergic effects that may decrease the stroke volume. The drug is not recommended for use as an addition to norepinephrine in this patient. Dobutamine is inappropriate for this patient because it is recommended only in the presence of myocardial dysfunction. There was not enough information in this case to assess myocardial function or ongoing signs of hypoperfusion despite achieving an adequate intravascular volume and using vasopressor agents. In this case, BJP has received adequate fluid resuscitation and with his MAP below 65 mm of mercury and SC, VO2 of 65%, dobutamine probably is not the most effective agent to add to norepinephrine at this time. Dopamine is inappropriate because it may be more arrhythmogenic than norepinephrine. Norepinephrine is more potent than dopamine, and it may be more effective for reversing hypotension in patients with septic shock. Dopamine may be considered for highly selected patients with a low risk of tachyarrhythmia and absolute or relative bradycardia. It is not the best choice for BJP, especially given his heart rate of 85 beats per minute. Please advance to the next question. And the next question reads, SCK, a 42-year-old male patient is admitted to the medical ICU from the general medical ward with septic shock. SCK is mechanically ventilated and receiving norepinephrine. His hemodynamic parameters include a central venous pressure, abbreviated as CVP, of 12 mm of mercury, increased from 9 mm of mercury, a mean arterial pressure MAP of 65 mm of mercury which is considered stable, a central venous oxygen saturation SC, VO2 of 60%, which has decreased from 72%, a pulse pressure variation PPV of 9%. His urine output is 0.25 ml per kilogram per hour, which has decreased from 1 ml per kilogram per hour. A stat bedside echo is done and it shows large ventricles, poor contractility, an ejection fraction of 35%, and inferior vena cava (IVC) collapsibility 8%. So my question to you is, which of the agents listed below would be the most appropriate intervention in SCK's current clinical scenario? Would it be A. dopamine, or B. dobutamine, or C. phenylephrine? Or would it be D. epinephrine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. dobutamine, and I will explain why. Epinephrine is inappropriate for SCK because his MAP, which is 65 mm of mercury, is already at goal, and epinephrine is recommended in the guidelines for septic shock only for addition to norepinephrine to raise the MAP to target. There is no benefit to increasing hemodynamic parameters to supratherapeutic levels because this will only increase the risk of side effects. Phenylephrine is inappropriate for SCK because his MAP is already at goal, that is 65 mm of mercury, and the addition of phenylephrine could decrease MAP and contractility. Phenylephrine is no longer recommended in the Surviving Sepsis Campaign guidelines for the management of septic shock. Dopamine is inappropriate for SCK because his MAP is already at goal, that is 65 mm of mercury, and addition of this agent could worsen hemodynamics and cause arrhythmias. Dobutamine is appropriate because SCK's echocardiogram shows signs of myocardial dysfunction. Additionally, the patient still has signs of hypoperfusion, with a decreasing SC, VO2 below 70% and low urine output less than 0.5 ml per kilogram per hour, despite what appears to be an adequate intravascular volume, as shown by increased CVP above 8 mm of mercury, ppV of 9%, and IVC collapsibility of 8%, and an adequate MAP, that is 65 mm of mercury. Please progress to the next question. And the next question reads, BLS, a 77-year-old male patient was transferred from the general medical ward to the medical ICU due to increasing oxygen requirements and altered mental status. He has a past medical history significant for a recently diagnosed with acute myeloid leukemia and is undergoing induction chemotherapy. His pertinent labs on admission to the medical ICU include a serum lactate of 5.1 mmol per liter, a blood pressure of 90 systolic and 45 diastolic, a respiratory rate of 28 breaths per minute, and use of accessory muscles when breathing. His serum creatinine has risen from 1.1 mg per deciliter to 1.9 mg per deciliter. His WBC count is 17.1 times 10 power 3 cells per millimeter cubed, hemoglobin is 6.9 grams per deciliter, platelet count is 16 times 10 power 3 cells per millimeter cubed. BLS is initiated on broad-spectrum antibiotics and given 30 ml per kilogram of IV crystalloids with a goal mean arterial pressure (MAP) above 65 mm of mercury. Despite fluid resuscitation, his MAP remains 60 mm of mercury, so a norepinephrine infusion is initiated. Currently, the norepinephrine infusion is running at 10 micrograms per minute, and the infusion rate has declined over the last 6 hours with MAP values above 65 mm of mercury. The intensivist on duty overnight orders a random cortisol level, which is 10 micrograms per deciliter. So my question to you is, which of the statements listed below about addition of corticosteroid therapy to BLS's current regimen is true? Is it A. It is recommended for the treatment of his sepsis without shock? Or B. It is recommended to allow reduction of his vasopressor dosage? Or C. It is not recommended because he is hemodynamically stable? Or is it D. It is not recommended based on his random cortisol results? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. It is not recommended because he is hemodynamically stable. A random cortisol level may be useful for diagnosing absolute adrenal insufficiency. However, random cortisol levels have not been demonstrated to be useful for patients with septic shock who suffer from relative adrenal insufficiency, inadequate stress response. Corticosteroids are not recommended in patients like BLS who are hemodynamically stable with adequate fluid resuscitation and vasopressor therapy. According to the 2016 Surviving Sepsis Campaign guideline, it is considered a weak recommendation, low quality of evidence. The one multi-center randomized trial to show a mortality benefit from corticosteroids included only vasopressor unresponsive patients with septic shock. BLS is responsive to vasopressor therapy. A large European multi-center trial that enrolled patients without sustained shock who had a relatively low risk of death failed to show a mortality benefit from corticosteroid therapy. Corticosteroids are not recommended for the purpose of allowing a reduction in vasopressor dosage in any sepsis treatment guidelines. Corticosteroids are not recommended for the treatment of sepsis in the absence of shock, according to the 2016 Surviving Sepsis Campaign guidelines and based on the results of the HYPRESS trial, which did not demonstrate a decrease in the incidence of shock in septic patients treated with corticosteroids. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 206.